Okay, let's go ahead and get started. It is 2 minutes past the hour, and I wanted to give people a chance to get in to the meeting. Chris, thank you for saying hello on the chat. Hopefully, I'm assuming that means people were able to get in without issues. So I'm Dr. Shauna Springer. I'm the chief psychologist for Stella. I'm joined by Paul Whitmer, who is one of the Stella ambassadors, which means that Paul is a patient who has been treated using the Stellate Ganglion Block that we'll be talking about, and he'll be sharing his experience with that as part of this new webinar series. This webinar series is going to be a monthly thing, so if any of your colleagues miss it, they can jump in next week, not next week, next month, and it'll be presenting an overview of what Stellate Ganglion Block is, talk about some of the research, how does it work with therapy, and then Paul will share his story. So let's go ahead and jump in. Today we'll be covering, as I said, the sort of overview of why this matters, what are some of the common barriers and how we approach trauma symptoms right now. What is Stellate Ganglion Block, or SGB, for those unfamiliar? A little bit of the history and research. Safety and efficacy is critical to address. How it works with therapy, and then we'll talk about Paul's story and where to go next. This webinar is for everybody. It's for patients, it's for potential partners, it's for providers that are going to provide therapy after the Stellate Ganglion Block. So it'll be kind of a broad overview for all comers. Let's start with why this matters. Now, there's so many reasons why this matters. It would seem kind of obvious to talk about how trauma is one of the biggest challenges that we all face now in the wake of all of the events of the past 2 years, and I'm sure we're all well familiar with that. And when you get big numbers like 144 million people will suffer from post-traumatic stress around the globe, that can be kind of hard to process. It can be overwhelming. But where it really becomes personal and real is that people with trauma symptoms are nearly 10 times more likely to die by suicide. And too many people across the country are grieving the loss of somebody that has died by suicide. This is not a veterans issue. This is a people issue. This is an issue of humankind, death by suicide. And in fact, 70% of those who suffer from trauma are non-military. There's also been, a lot of events in the past couple of years that have really made our trauma load much, much more difficult to bear. And so to put some numbers on that, we have the number of COVID cases and COVID deaths, but we also have data on a large number of people, between 18 and 36% of people experience trauma symptoms, post-traumatic stress symptoms in the post-illness phase of COVID-19. I don't know if that will change with Omicron, in theory, because it doesn't feel quite so unknown, and it tends to be a weaker strain, especially for those. It would appear the data says if you've been vaccinated, it's going to be a weaker strain in most cases. So I don't know if those will bear out, but as far as the emerging COVID crisis, this was data pulled from, those first 6 to 8 months of people with COVID who felt like maybe this was going to land them on a ventilator. Also, during the time when the shelter-in-place orders were taking effect across the country, domestic violence calls increased dramatically. For many households across the US, this was a time of helpless rage and frustration, and people were losing jobs, people were stuck at home, and everybody's sort of equation changed very quickly. And so there's been a lot of increased incidents of domestic violence and all of the trauma that comes from that as well. And the way that we treat trauma symptoms now is often give you, therapy for trauma and sometimes medications, often SSRIs or selective serotonin reuptake inhibitors, things like Zoloft, for example, or Prozac, may be treatments on the medication side that are first-line current treatments for trauma. But there's a lot of barriers to care, which is why I believe that innovation is really important. I believe we need to innovate like lives depend on it, because they do. And there are many reasons for this, including mental health stigma around, going to get treatment for a mental health problem, as opposed to something which is a physical injury caused by trauma that changes how our brain functions, which can be healed. So shifting to an injury model versus a mental disorder has advantage of eliminating stigma. A lot of people are concerned about receiving a diagnosis. People in certain professional careers, this can impact them, and they're really concerned about having that diagnosis charted and shared with, potentially an employer, or having to disclose it on a job application. It shouldn't be this way. I think all of us struggle, but the reality is that diagnoses can matter to people. And there's also a high dropout from care with current treatments. The current standard of care is often to make people face what they would rather avoid. And so a lot of people drop out of care or refuse to enter care in the first place, because the proposition is, I don't know if I want to talk to somebody I met, even a professional therapist. This is me saying this as a psychologist. I don't know if patients want to talk to someone about the worst day in their lives in detail. So that is an obstacle to care. If they talk about that experience multiple times and they get all the way through it, that treatment can be helpful. But a lot of people will not even enter the treatment because they're turned away in terms of the difficulty of facing problems that most of us would rather avoid. And to that point, there's often with current therapies an increase in symptoms, a spike in symptoms, and they get worse before they get better. And that can be when some people drop out or suffer before they experience relief. That can be an obstacle to care for some. Treatment can take many weeks to several months. Many patients don't want to be on medications. So when medications are offered, that may be an obstacle to care. And then the cost of traditional treatment, if it takes place over a long span, can really add up. So those are some of the current barriers to the care that we offer right now as frontline treatment. And SGB offers us a different way forward. This is a really big shift in how we think about trauma. It's not just another, quote, tool in the tool belt. It is actually part of a paradigm shift in terms of how we see trauma and how we address it. And SGB is based on neuroscience. It's based on innovation that says trauma is not invisible. It's not an invisible wound. It's actually visible with the right brain scan. And it's not mysterious. You can see it and you can heal it, because in part, trauma causes a biological injury. Now, trauma also changes our thinking and behavior. So I'll talk about why therapy is still critical as part of healing, but I believe that therapy alone for many people is not going to get them the results that they need and ending their suffering with efficiency. So I believe it's an improvement and a paradigm shift in terms of how we treat trauma. So stellate ganglion block is a cluster of nerves in the neck area, about here, that is associated with the fight or flight system. And if trauma leads to biological changes, if trauma is an injury, then stellate ganglion block can target the symptoms of post-traumatic stress by the application of an anesthetic medication. So an anesthetic medication, specifically ropivacaine or bupivacaine, is injected into this cluster of nerves in the neck, which seems to bring an overactivated system back to a state of calm. This is not a new treatment. If people are not familiar with it, sometimes they think, oh, it's new or fringy. It's actually been used since 1926 as a pain treatment. So developed for pain, but there's early documentation in the medical literature about application to depression, and actually in 1990 to a case where a 15-year-old girl had post-traumatic stress. So back in 1990, there was an incidental reporting of how the stellate ganglion block helped calm her symptoms and helped her approach therapy. And then since 2008, we've seen kind of an explosion of articles on how stellate ganglion block has been used specifically for trauma. But it's a little bit like we use aspirin to treat cardiac risk factors. So if you have risk of heart attack, aspirin is often used daily because it's known to be safe, and it's an FDA-approved pain medication that's known to be safe. It's used to reduce cardiac risk factors because it has shown benefit of that consistently over time. So that is an off-label use. Aspirin wasn't developed for cardiac risk factors, wasn't developed for heart attack risk, but it can be used in an off-label way because of lots of documentation that it's a safe medication to use. And in the same way, there's been studies of stellate ganglion block, and one study alone in 1992, 40,000 people received stellate ganglion block in a study conducted in Germany. And the incidence of side effects was extremely low. And that was even before we had the imaging technology that we use now to really locate where the injections should be placed. So it's really not a new treatment. It's been adapted to treat traumatic stress symptoms since 2008. And there's actually political momentum behind stellate ganglion block becoming available across the country for veterans. This Treat PTSD Act, HR 1656, if you want to look it up, would require the VA and the Department of Defense to provide stellate ganglion block to veterans and members of the armed forces who are diagnosed with PTSD. And it requires the VA and DoD to update their practice guidelines to ensure that people know about this option. And this has been endorsed by all three of the largest national veteran support organizations. The VFW, AMVETS, and the American Legion have all endorsed the Treat PTSD Act and said, let's make this available. There are, last I checked, 22 co-sponsors across both political parties, representing a wide variety of regional areas across the country, saying, let's move on this. Let's make this available for those who choose to have it. And so just, as I said, it's been in use since 1926. In 1947, there was a study of SGB used for psychiatric, for depression. 1998, there was a study in Finland where SGB, not SGB, but something similar to SGB, T2 clipping is what an anesthesiologist or physician would call this, but essentially targeting the same cluster of nerves and nerve pathways to relieve hand sweating, and PTSD symptoms were also relieved. In 2008, Dr. Lipov published the first study in the medical literature on SGB prospectively used, proactively looking at, does this help with trauma symptoms? So before that, there were some incidental findings, but nobody really picked up on it. There were no follow-up studies. It's not like anybody really realized, I think, what they had observed, or else we would have seen earlier studies when it was documented previously. There's been a lot of really important research that's come out since 2008, and I'm going to hit on some of the most important research projects here in the next little run. But this first patient, I want you to know how really, what is the phrase? Necessity is the mother of invention. So Dr. Lipov had a patient that had been robbed at gunpoint, and he was on his way to an inpatient unit. His trauma symptoms were so bad that he was going to be in an inpatient unit where he'd get full coverage care, 24 hours care. And his SGB was basically his last stop before he headed to inpatient care. And after the SGB, his symptoms dramatically dropped, and he no longer needed to be admitted for inpatient care. So that was the first case study that was written up and really showed Dr. Lipov, who is a colleague of mine at Stella and our chief medical officer, showed him the potential of SGB to treat trauma. And no innovation is, a one-man show. There's been a lot of studies that have come out from different research teams and individuals. And here are some of the most important kind of broad strokes findings. So across the board, different research teams, investigations have shown that the positive response for stellate ganglion block ranges from about 70 to upwards of 80% success for stellate ganglion block. And that's a very high success rate. It compares very favorably and improves the performance of our current first-line treatments for trauma. It also showed significant results, significant positive results, very promising as a treatment for PTSD in an RCT. An RCT here, for those unfamiliar, means randomized clinical trial, where not everybody got the same treatment, and it was sort of doled out who would get what treatment on a randomized basis. And the conditions were compared, outcomes were compared, and SGB was shown to be very promising. Also, Lynch in 2016, I would say this is an important study because it showed sustained relief from hyperarousal PTSD symptoms. Now, what does hyperarousal mean here? Hyperarousal refers to the kinds of symptoms where you're always very agitated and your fight or flight system is constantly locked into an activated state. So symptoms specifically like difficulty sleeping, sudden floods of irritability or anger, floods of anxiety or panic, and hypervigilance, always kind of your head on a swivel looking for the threat. And difficulties concentrating would be one. And the startle response would be another hyperarousal symptom. So if somebody walks up behind you, if there's a loud noise, you kind of jump out of your skin. So SGB doesn't just help with these symptoms for a short time, it can bring sustained relief based on a procedure that takes about 15 or 20 minutes in most cases. Also, Dr. Mulvaney showed that far from blocking people, because it's called stellate ganglion block, that's because it comes out of the pain discipline, and pain physicians refer to the operations they do as pain blocks. You want to block pain. But remember, this is not really used for pain. When you apply it to trauma, there's a different indication, different reason you're using it. And it doesn't block you from feeling emotions, or it doesn't numb you out, quite the opposite. It doesn't prevent you from being able to respond if there's a real threat in your life. And this is important. It's important for veterans. It's important for those who are active duty, who still need to be on point when they're deployed. And it's important really for anybody who's been under threat. You need to know that you're not a sitting duck. You need to know you can respond if your environment produces a threat. And so far from, blocking you, SGB actually improves reaction time and other neurocognitive functions. So people can respond actually even more quickly than they could before the stellate ganglion block. So that has some implications for active duty military. SGB has been used in the special forces community as a performance enhancer. And for everybody that's experienced trauma, it just communicates that, this isn't going to put you at a disadvantage should you be targeted. There's also a study by Brian McLean. Dr. McLean is a physician who works at Tripler Army Medical Center in Hawaii. And he looked at a very sizable sample of 250 soldiers who received the stellate ganglion block, and 100% were satisfied and would recommend it to a friend. And so I think that's really important to note and very telling about what do the people that have had it say. We have a lot of opinions and commentary from people at times that have not had the treatment. I don't mind sharing that I've had the treatment myself, and I would heartily recommend it. I don't suffer from trauma symptoms, but I was just curious about whether it could help with my sleep. because my sleep hadn't been great for years. And so I just kept hearing these reports back from my patients about how they were sleeping better than they had in years. And I said, I'm going to see if this could be indicated for improving sleep. And it did. And I have the data to show it because I track my sleep patterns with my watch. And it really helped me. So I would join the people that say, yeah, it was quick, it was painless. I didn't have any sedatives or local, anesthetic to put me under. I was fully alert and aware, and it really helped improve my sleep. And those who have worked with the physicians who provide this, the behavioral health providers and therapists, of those, 95% of them would also recommend SGB. So a staggering majority of those people would also recommend SGB. I don't know why the 5% person wouldn't, but there is an overwhelming majority that say, yes, this is something that really works well with therapy. And I'll talk about why in a minute. My first patient was back in the VA when I worked as a psychologist in the VA. And I saw several patients, about several meaning 4 or 5. So not a high volume, but they all consistently had very positive outcomes. And it was eye-opening for me to see them go through this because it works very quickly. There is a profound shift, positive shift, usually within 20 to 30 minutes, if not immediately after the procedure. And, he followed up with me 5 years after the SGB. So he reached out to me just recently, back in September of 2021, some months ago. And this is what he said: I want you to know that you saved my life, and SGB gives people hope. You saved my life back then. I didn't tell you how suicidal I actually was. And he's like a lot of patients who will say to me after the fact, after they come out of the woods, I was too afraid to tell you how suicidal I actually was, how much in danger I actually was at that time. That's quite common among some of the populations I've treated. And so that he followed up 5 years after, found me through social media, I think, and told me this, I thought was very telling. Now, this was an interview that I did with Dr. Eugene Lipov there on the lower left and Dr. Brian McLean on the lower right, 2 of the leading SGB pioneers in the country. This was not long after I had started to see the effect on just a few cases. And so I'm there as an interviewer in this situation with my co-host for a television program I work with out here in the Bay Area. And this is kind of my skeptical face. This is me saying, really? Let me ask you some hard questions about that, because I started very skeptical and very careful. And the results I've seen over time have been extremely compelling. And now I try to have patience with people who say, well, let's wait another couple of years and see what the research tells us, because I realize that people are dying because they realize that, or they don't realize, they think that their trauma has broken them and that their PTSD is a life sentence. And that's something that needs to end right now with innovative treatments like Stellate Ganglion Block. But it won't end as long as people are fearful and risk avoided for something that's actually quite safe in the hands of a skilled physician. So look at the difference of my face now. So here's, when I was skeptical, I first met Dr. Lipov on that day, and then we started co-treating patients. And one of the trips I took was to Chicago, and we treated 10 people in the same day. And by we treated, I mean he did the injections, and I, excuse me, he did 10 injections on people that I know well. They were all Marines actually that day. Some of them knew each other, which is cool. And then I was doing the psychological bedside consults and really kind of walking with them through that process. And that was the day when I really, to come out of that day and say, well, I don't know if it works. Let's wait another couple years and see what the research tells us, just was not an option for me after that day. So that was a very memorable day and a turning point in my career where I think one of my major messages is just because you don't offer the treatment doesn't mean you shouldn't make it available for your patients and work with physicians, because it enhances everything we do as talk therapy providers. Stella started back in 2020, and we now have, it's hard to keep this map up to date, over 40 clinics in the US. We have clinics in Australia, and we are launching in a second country, but I'm not able to announce that quite yet until we formally launch. So very rapid expansion of services across the US, and now starting into international locations. Let me talk about some of the outcomes that we're seeing. How effective is this? So if you have a 10-point drop on the PCL, PCL is a widely used across the VA and other healthcare systems, widely used measure of symptoms. Patients, they check off the severity of their symptoms and then they rate it afterwards. And a drop of 10 points is something to celebrate, according to the National Center for PTSD. That is a clinically significant improvement. On average, what we've seen in our data at Stella is nearly 3 times what would be considered something to celebrate. So really practically, this is like taking somebody with very high symptoms back to a level of really being calm and able to function at a whole different level. And we've treated thousands of people. So this isn't based on, just a couple of cases. In fact, this study was based on about 327 patients. The study will be published in, I think, about a week from now. Today is January 11th or 12th, and it should be out in about a week. So this is based on 327 patients, but we've seen this outcome consistently across more than 3,000 patients that we've treated in the past 2.5 years. And one of the other findings in this study was that, Stella has treated a lot of civilian patients, as well as about 30% of our military and service member veteran cohorts are with military or service member backgrounds. So most of the people that we treat, in other words, are civilians with a wide variety of traumas: domestic violence, sexual assault, bullying, childhood traumas, street violence, you name it, we've treated it. And across males and females, across different ages, military, civilian, different trauma types, the results hold. This is a successful treatment, and it works uniformly across different cohorts that had different traumas. Now, as a psychologist, I don't touch the needles, but I do work with the physicians who do very closely and have done enough of this work to really realize the big aha for me was when we bring patients into trauma-focused therapies in the wrong mind state, they can't benefit as much as when we get them into the right mind state by addressing the biological injury first. So when you bring patients in and they are overactivated and their fight or flight system is constantly on overdrive, they often approach therapy out of a fear or reluctance or dread, even stronger, instead of hope and confidence. And so getting them calm in their own bodies really just totally shifts the mind state when they enter and go through therapy. And we also know that when the brain is under high stress, people have difficulties with concentration and memory. And therapy takes a lot of cognitive work. You have to review things that you've gone through. You have to think about where you are now, kind of compare those. You're retrieving old memories, trying to build new insights, and the brain does not function well under high stress. So treating people when they're in the wrong mind state, when they're not really with you in the room. They're there, but they're not in the room because they're so distracted by the severity of their trauma symptoms is not as helpful as treating their trauma symptoms first. So SGB has really helped address the mind state barrier among my patients. The things, that we know from research that trauma leads to is, confusion, concentration difficulties, memory, all those things I talked about. And so when you get people calm in their own bodies, they feel a new level of willingness and confidence as they navigate therapy. They are able to hear you as a therapist and deeply integrate the insights that they gain in therapy. And through this process, SGB accelerates and enhances the work that we do as therapists. That is one of my core messages now, and I will keep saying that. We need to we need to combine what we do with the people who provide this treatment if we want to get our patients the best outcome. So therapy is still critical because trauma changes how we think and how we behave. So SGB opens up a window of opportunity and creates these optimal conditions for a good outcome, but patients really still need to do the work to get long-term gains. They can't just, get a treatment, get calm, and then keep doing the same things that they're doing because then their anxiety may return, often sometimes within a matter of months, versus taking the opportunity in a calm body to think about the trauma, think about it differently, change the way they interact with other people, whether it's loved ones, coworkers, however, and really reach a new normal based on the work of therapy. That's what therapy can do for people. And that's why it's always going to be a critical part of healing. All right, I'm going to turn it over to my colleague, Paul Whitmer. Paul, can you unmute so I can make sure we can hear you? Hey, Kevin Briggs is here. My friend Kevin, good to see you. And Robin, yes, we have to add a Louisiana dot to our map. Paul, I'm still not hearing you. Oh dear. Let me see if I stop share. Paul, can you say something now? Paul Whitmer, I'm here. Paul, are you trying and you can't be heard? Can you unmute? Did I add him as a panelist? I didn't think I had to. How do I do that? Let's see. Participants. Yes, add me. Okay. I don't know how to do that. I thought he was a panelist. Anyone can chat with hosts and panelists. Penny, can you help me figure out how to do that? Attendees, let me see. Oh, Blake is on too, and Ed Nicely. Hey, good to see you guys. Hey, Christine. Oh, okay. Allow to talk. How about now?
Hey, how about now?
Yes.
Yeah.
All right.
Cool.
I'm going to put myself on mute. You take it away.
Okay, Doc. Hey, thanks for having me and welcome everybody. It's an honor to be here, an honor to speak with you. Can you hear me okay, Doc? Thumbs up. Okay, cool. Well, I received an SGB injection about 10 months ago. So I'm a little ways into it, and everything is right on track. My relief is at or better what it was the day I received the injection. So as for long-term effects, I'm 10 months in and I'm really pleased. I'd kind of like to field some questions if you got them. So if you guys want to type them in, if you've got something on the side, but I'll just start kind of going over Doc, is that okay? Just kind of hit on my story a little bit. Great. So I'm an Army veteran, multiple tours in Iraq and Afghanistan. I returned from service and retired. Had a lot of trouble with insomnia. Could not sleep. Hypervigilance, short-term memory, anger, frustration, anxiety, and depression. So we had the whole gamut, all rolled up. I had one problem though, one obstacle to care, especially to CPT and PE. I didn't have a singular intrusive memory. I didn't have that one time where everything went wrong. And so, we could prod and poke and go through the history of all the deployments and all the interactions with, where trauma could have been, incurred, but we couldn't put our finger on the one time, the one thing we need to sort of focus the CPT and the PE on. So that was kind of a barrier to, it was hard on the patient, it was hard on the clinician. I found that when I received my SGB injection, I will tell you that immediate improvements in sleep. Okay, so what Doc mentioned earlier about sleep, I felt the same thing. Sense of calm. I just had an overall sense of calm. I didn't feel drugged or droopy or dreary or medicated. And quite the opposite. I felt like the anxiety had been decreased and I felt more aware and more alert to my surroundings. So the decrease in the anxiety sort of opened the doors for everything. And one of the things you mentioned earlier, Doc, on obstacles to care is, a person might have a difficulty facing a problem. And like I mentioned earlier, I kind of had a difficulty identifying a problem. But after receiving the SGB, I have found that my interactions with therapists where yes, and you hit it on the head. You said, hey, they're in the room participating, but they're really not engaged. And I will tell you that's exactly how I had been for several years. Post SGB, I'm able to really feel and get the benefit of the therapy and the therapist. I work weekly with a gentleman you just mentioned, who's on. And I've also allowed myself to go and participate in some of the warrior retreats that are out there, and really have gotten a lot of good stuff out of those. A lot of good stuff on grounding and meditation, things that I just never seemed to work for me. Now they're really working for me. So it's really been good. Can I take a break for a sec, Doc? Anything you want to say?
Yes, actually, I was just going to text Christine Ray Olmsted because we are blessed today to have the first author of the randomized controlled trial on with us as well today, the 2019 JAMA Psychiatry study. Christine, now that I know how to make people able to talk, I'm going to invite you to share with everybody who's here, what you found in that study and really anything you want about SGB.
Hey Doc, how are you? Can you hear me?
Good. Yeah, we can hear you great.
Great, thank you. Our study, as you mentioned, found that SGB was effective in a sample of about 115 service members. We took all comers, much like your data show, regardless of trauma type. And I think that's really an important finding of both our research and your research, is that it's not just combat trauma. It's all trauma types. I get that question a lot, and I'm sure you do as well. One of the things that we also did with our study was we did qualitative interviews with service members, both who had received SGB or who were feeling better and who weren't feeling better. And even the people who weren't, these are unpublished data as of yet. Even the people who weren't feeling better said that they would try it again and they would recommend it. The people who were feeling better, we had people, offer to be testimonials and, had these incredible stories. Many times when people are feeling better, they want to be heard. They want to tell you their story. And that can be hard, but the joy on the faces, the relief on the faces was so very gratifying. And so, Shauna, do you have questions for me specifically that I can answer?
What do you make of the fact that even people who didn't get the positive response wanted to be retreated? I'm curious about that.
Yeah, my own personal hypothesis is that they were hopeful that a second treatment would be helpful. They had read in many, many instances that some people require more than one treatment. And we know that to be the case from other studies as well. And so I think, part of the reason they would be willing to recommend it was because they had seen such tremendous success in their friends and their colleagues, their fellow service members. Excuse me, I'm fighting a cold. And they universally said it wasn't painful, universally said it wasn't scary. It's not like a very, intrusive medical procedure. It's pretty straightforward, and they were really very positive, even if they weren't feeling better. So, and nobody was feeling worse, I'm thrilled to say.
Now, what was, if you could share with us, because I've been in the OR and I don't know that many people who have been in the OR, but what was your experience kind of watching this transformation for the first time as a researcher involved in this huge project?
The experience was tremendous and life-changing, in all honesty. We saw people who sat up on the table with tears in their eyes because they felt so much better, like a weight had been lifted off their chests. One special operations soldier was one of these people who sat up on the table and was just like blown away by how much better he felt. And so for me, it was really not only moving, but life-changing in that, I really work with service members, primarily with PTSD as a researcher, and to know that there was something available that could be this extraordinarily moving was really profound and made a big change in my life as a researcher.
For me too, boy, it was transformative. It shifted my paradigm. And, the analogy that you gave in an interview you did on a radio program was that this is like injecting Novocaine when you go to the dentist.
Mm-hmm.
It doesn't stay in your system. Can you say a little bit more about that? Because one of the common misconceptions that I think you could well clear up is that, this is kind of a medication that's injected and it kind of stays in your system, but it actually doesn't.
Yeah, as you mentioned, Doc, it's usually ropivacaine, sometimes bupivacaine, and it is, in my mind, much like the Novocaine that you would get at a dentist. It's longer lasting. And when it wears off, people think, well, how can this possibly help when the anesthetic wears off? Well, it does. The effects linger after the anesthetic wears off. And to me, that's the remarkable part of this is that, how can this be? How is this a thing? And, it's just really powerful that even when the anesthetic wears off, the effects linger. And as you mentioned before, some people have been really concerned about long-term, slowing of reaction time or things like that. Our study participants were active duty service members, and they have to be able to work on the, fire on the range. They have to be able to react quickly. That's part of their deployability. And other research, I think by Dr. Sean Mulvaney, has shown that reaction time, in fact, does not decrease. In fact, it gets better, which you also mentioned. So it's really, the whole of it is compelling, I think.
Yeah, and you're doing some follow-up analysis. I think you have another research grant. Can you tell us about what you're up to next as far as the next steps with the SGB research?
Sure, happy to. We have one grant that is for a continuation of analyses of the randomized controlled trial data to answer more questions about things like concurrent medication use. Does, most people are, many service members who have PTS are on medications, and for that or for other things. And so what we did was we looked at the degree to which concurrent medication use served to mediate or moderate the impact of SGB. Those data are forthcoming. Our new study is a prospective cohort study. And for those who may not be familiar, what that means is instead of randomizing a group of people to one treatment or the other, like in a randomized controlled trial, a cohort study follows a cohort of people who are enrolled over a given period of time. So we've got 5 research sites, and we will be following every consenting service member and veteran who receives a stellate ganglion block. We will be following them for a period of a year. This is a real benefit because it's a longer term follow-up than most studies have been. We're looking at everything from treatment symptom trajectory to the degree to which neurocognitive functioning changes. We anticipate that neurocognitive functioning will improve, but the data will show either way. And we're looking at things like adverse events, which, as you mentioned, Doc, in the literature have been extraordinarily rare. But in following people for a year, we'd like to think that we can capture any adverse events. And finally, we're looking at people. Nobody has studied yet the impact of receiving multiple SGBs, to the best of my knowledge, at least in the literature. So many times, as I think you mentioned before, a service member will get an SGB, and then maybe they feel better for a couple of months. And so they go get another one, and maybe they feel better for 4 or 5 months. And they're kind of cumulative in some people. So we want to be able to evaluate the degree to which we want to tease out for whom one treatment is enough versus the cumulative effects of multiple SGB treatments. So that's our current study.
That's awesome. I'm so glad you're going to follow them for over a year and really look at those questions. Christine, you've had a front row seat to really this innovation. And the two of us have really probably observed some of the common barriers to people really accepting this in terms of care providers or systems. What have you noticed have been some of the common barriers to systems or providers saying, yes, we should be offering this as an option?
It's an excellent question. I think one of the biggest barriers is a lack of knowledge about the procedure. When we spoke with, not only did we speak with service members at our 3 sites for our randomized controlled trial, we also spoke with their spouses or partners, and we also spoke with providers, everybody from SGB providers to chaplains to behavioral health providers. And overwhelmingly, the response from behavioral health providers in particular were that they thought this was a big involved medical procedure. And, they were interested in potentially watching an SGB to learn more about it, but they were asking, for instance, if they would need to scrub in. And, like it's a surgical procedure. And they really felt like this was a scary thing. And so there's a lack of knowledge out there about what all is involved. Another thing that I think can potentially serve as a barrier over and above lack of knowledge is concern about, this might not go over well with some populations, but concern about, I don't want to say territoriality, but a lot of behavioral health providers, they believe in what they're doing, and that's great. They believe in what they're doing. SGB needs to be an adjunct like what you're doing with the Stella Center. It needs to be an adjunct to talk therapy, to psychotherapy. And I think many times behavioral health providers feel like their toes are being stepped on when in fact we are reaching out with a hand to say, help us. Those are the two primary barriers that I see.
I totally agree. And thank you for saying that, because, I will back you up 100% on the territoriality of what I've observed, and it does come from a good place. I think providers, want to do right by their patients. They believe in what they offer. They see that it works. And for me coming into this, it was really making a shift in understanding, yes, what I do works, but wow, it could be so much more enhanced or powerful if I teamed up with people that do biological treatments for trauma and really lay the right foundation for all of the work I do. So I think there's a path there for us to really collaborate. And there's so much trauma that we urgently need to do that.
Absolutely.
And really shift that.
Yeah.
Christine, thank you. Sorry to kind of, you didn't probably know that you were going to be pulled on to the stage here, but and Paul, we get to do this with each other every month. But we had Christine on today for our launch webinar. And so she is a tremendous pioneer and researcher in this space. And I wanted to ping her with some key questions. Paul, let me go back to you for a second and see if anything that Christine shared or anything you wanted to add to what you shared, or people feel free to put questions in the chat and I'll pick them up from there as well.
Sure. Hey, and by the way, Christine and Sean are both, I have read and read and read a lot of research. I got into SGB in graduate school back in 2019, writing a paper on alternatives to CPT and PE, and I stumbled into SGB, never once thinking that 2 years later, I would get an SGB myself. So I'm very familiar with your writing and your research, and thank you so much. I'm really pleased that I was here today.
Thank you for the kind words, sir.
So Doc, I think that, and both you guys just kind of nailed it. I don't see SGB as a standalone. It's not a silver bullet, but it is to augment behavioral therapy like CPT or PE, or I see it as a tremendous vitamin to that, a tremendous assist for that. And I think that's kind of what both you guys. Well. Okay, Doc.
Paul, I think you're on mute.
How about now? We good?
That's good. Last thing I heard was it's a tremendous assist to therapy.
Yes. Yeah. And I feel that the SGB may be significantly better, but the real benefit that I received was it opened those doors and allowed me to converse with my therapist, and things started to make sense. Things started to sink in. And before, I was just a participant that was there in the room getting information, but not processing it. Does that make any sense?
It makes 100% sense to me. And if there's one thing I could shout from the rooftops to every therapist out there is, you are irreplaceable. You are irreplaceable as a healer in this equation. And that if your patients come into therapy in the right mind state, it's a different equation. It's a different proposition to say, let's walk into this space of addressing your trauma when you're not feeling all jacked up in your body and overwhelmed by the intensity of these horrible symptoms. Let's approach what you would rather not from a place of calm in your own body. When you can look at things that way, when you're calm in your own body, new insights emerge and people are able to hear. So I had this humbling experience with my first cases where, I would do therapy with them for months afterwards, sometimes, or weeks in some cases, because it was so fast that it took root, that I would say, I know we've talked about this before. I know that we've covered this ground, and realized how much of what I was saying and working with them on just really didn't take root, didn't really stick. And to me, it was the revelation around it's because you have to put people in the right mind state first. And that is why, you know, plug for people not thinking, well, this should be a treatment that we offer because other things haven't worked. I think to Christine's point, sometimes there's a lot of misconceptions around what the treatment is, that it's not some big surgical procedure. It's 20 minutes, you know, it can be done on an outpatient. I had no sedatives. I laid on a table. It was 15 minutes, 20 minutes, and I was done, fully alert and awake and talking to the provider the entire time. I woke up the next day after my first night of really good sleep in a long time. Paul, you can back me up on that because you haven't gotten any 3 a.m. emails from me lately. No bruise on my neck. I did an interview for Hollywood Times that you can Google on YouTube the next day after my SGB. It's kind of like a cool time capsule where I just was rested, and it was so quick. And so I think, you know, people who think, oh, this is a treatment of last resort, don't understand how safe it is in the hands of a qualified provider, how quick it is, and why it's critical to do this before you do the therapy. That is really strategically critical. So thank you both. We didn't really get any questions. We did get a comment from somebody in the chat, which I agree with, that one of the reasons why SGB is such an important treatment is because it looks at the whole person. It doesn't just break out, you know, one little piece of trauma, but it really looks holistically at a person's physical system and their psychological and emotional and relational system. And so to me, SGB is kind of the fulfillment of the potential of the biopsychosocial model. And we've talked about that for years in the field of behavioral health. Biopsychosocial assessment, biopsychosocial approaches to treatment. But in reality, I haven't actually seen that really deeply play out until I started working with physicians who provide the SGB. And now I see the potential realization of that model. So Paul, Christine, thank you so much for your wisdom and what you shared, your stories, and really appreciate everyone for taking time out to be here today. So we'll sign off for now, but if anybody wants to follow up, partner with us, heal, provide therapy, we work with the providers across the country who provide the therapy that's critical after SGB. Reach out to any of these contacts. And with that, I'm going to sign off and wish you all a good day.